Hello my dear students, I am Dr. Vaishaly Bharambe. I have been teaching anatomy for last 25 years and I love it. Today I am going to discuss the pectoral region with you. I am sure you know whose pectoral region this is, but we will not talk about it. Okay? Right. So when do you look at pectoral region? When do you have to study it? Normally you are just starting superior extremity. There is a cadaver lying in front of you. You are expected to study pectoral region by dissecting the cadaver. So what is the cadaver covered by? It's covered by skin. You remove the skin, you will find superficial fascia below it. Go further, you will find deep fascia. And were you to remove the deep fascia, you would find these 4 muscles there, right? So that's what we're going to study today. So before that, I want you to quickly palpate some of these points that I'm going to show you. Why do we palpate? You can palpate on yourself, you can palpate on the cadaver, whatever works for you. Okay, right. So now you can see here, this is your clavicle. Can you palpate it please? Okay, yes. Come medially, this will become your sternoclavicular joint. Go laterally, that will become your acromioclavicular joint. Just keep correlating with the screen. Okay, right. Here is your manubrium sterni. Go above it, the jugular notch. Go below it, that's where it articulates with the rest of the sternum, forming the manubriosternal joint. That's where your second rib comes and articulates. How does it matter, madam? Of course it matters. That's how you're going to palpate your ribs. You're going to identify ribs because you know that the manubriosternal joint has the articulation of the second rib on it from both the sides. Right. Coming further, you come to the 4th intercostal space where slightly medial to the mid-clavicular line, you will find the nipple in case of males and the nulliparous females. Of course, in the adult females, the position is very variable. Right. This is the mid-clavicular line. This is the mid-axillary line. You should know both. This is the infraclavicular fossa. Ideally, you should have one. Unless then, if you don't, maybe you should be gymming a little bit. Right. Then this is your coracoid process. Best felt if you were to grasp your own shoulder. Usually these digits will be feeling your coracoid process. I can feel mine. You should be able to feel yours. Here is your acromion process. And then further, these are all your the spaces between the ribs. Okay. With this base knowledge, let's go back to the cadaver. You can see the cadaver covered by skin. Take an incision, reflect the skin. Now you come to superficial fascia. If you have very fat cadaver, lot of superficial fascia, lot of adipose tissue, you're not going to see anything. All you see is fat. Now have faith and begin to remove that fat. As you remove the fat, you find cutaneous nerves, blood vessels, platysma, and in case of females, adult females, a mammary gland there. Which nerves will you find? You can see a lot of nerves here. Okay. So the nerves you will find are anterior cutaneous nerves, just lateral to the sternum. These are from T2 to T6. Laterally, you find lateral cutaneous nerves from T3 to T6. And one of these is going into your arm as the intercostobrachial nerve T2. Were you to draw a line from the manubriosternal joint horizontally, everything above it is supplied by C3 and C4 nerves. Everything below it is supplied by T2 downwards. So question is, where is C5 to T1? Do I need to tell you where is C5 to T1? I don't think so. I'm sure you know that C5 to T1 forms brachial plexus and therefore does not give rise to cutaneous nerves supplying your pectoral region. Right. What else do you find here? In this same superficial fascia, you find the mammary gland, which is covered by skin. Please keep watching. Superficial fascia, retromammary space, and then the pectoralis major covered by deep fascia covering pectoralis major. So mammary gland is just a gland present in the superficial fascia in females. A separate lecture on mammary gland has already been uploaded. I suggest you go watch it because this is a very important topic, not only from point of view of exams, but also from point of view of life. Right. So this is what you see: fat, cutaneous nerves and vessels, mammary gland and platysma muscle. Were you to reflect all of this, what do you get? What should you get? Skin, superficial fascia, then deep fascia. So you will get deep fascia, which is, just keep looking at this, which is intimately attached to the underlying pectoralis major. In fact, there are a lot of septae going into the pectoralis major, anchoring it. It is superiorly attached to the clavicle, and inferiorly it winds around the lower border. You can see it here. It winds around the lower border of pectoralis major to become continuous as the axillary fascia. It's the fascia that lines your axilla. Right. Students, if you are enjoying this, please do remember to like and subscribe to my channel. Also, I suggest all of you begin to visit my website. I am giving you MCQs per lecture. Okay, and remember, your MCQs is what is going to test you for your PG entrances. So ensure you go on the website and solve these MCQs regularly. Some are easy and some are challenging, I am telling you. Okay, right. So now let's move on. So you have removed the skin, you removed superficial fascia, you removed deep fascia. अब क्या है? अब 4 muscles है. The pectoralis major, pectoralis minor, subclavius and serratus anterior, out of which some are easy to understand, one odd might be a little challenging. Let's start with the biggest and the most visible. The pectoralis major comes as a short note very often. Be prepared. It's a massive muscle that takes origin partly from clavicle, partly from sternum, partly from ribs. Okay, so let's understand. From the clavicle, the middle half of clavicle anterior surface gives rise to what is called clavicular fibers of pectoralis major. Can you say this once? Clavicular fibers of pectoralis major. If there are separate clavicular fibers, there have to be separate sternocostal fibers taking origin from sternum and the costal cartilages adjacent to it from 2nd to 6th. You can see that here. So one set of fibers coming from clavicle, one set of fibers coming from your sternum and the costal cartilages. Okay, these are 2 separate lamina, an anterior lamina and a posterior lamina. They get together inserted on the humerus in the form of a U-shaped attachment. Come take a look. You can see the U-shaped insertion. The anterior lamina gets inserted on the shorter limb, the posterior lamina on the longer limb. But the peculiar part of posterior lamina is that upper fibers pass downwards, lower fibers pass upwards. So they kind of cross each other, and as they cross, they create a fold, which is your anterior axillary fold. You must remember this. You must try and visualize this. My way of doing this is very simple. Usually I just take a handkerchief, okay, and twist it. Just twist it, okay. So the lower fibers have gone up and the upper fibers have gone down. That's all that is happening there, okay. See if you can understand this. So that's pectoralis major origin and insertion. What is its nerve supply? It gets its nerve supply from this, the pectoralis major, covering the underlying structures, which is basically pectoralis minor, piercing which comes your medial pectoral nerve, and piercing the clavipectoral fascia comes your lateral pectoral nerve. So what is nerve supply of pectoralis major? Medial pectoral nerve, lateral pectoral nerve, both of which finally contain all 5 roots of brachial plexus, which makes your pectoralis major unique. It's the only muscle that gets supply from all 5 roots. Right. So what is the action of this muscle? It's massive. काम भी बहुत होगा ना उसको. You must be having a lot of work to do. What work does it do? So because it's going from your chest to your arm, it's going to medially rotate the arm, it's going to adduct the arm. Easy. What it also does, wait a minute. So that's your scapula, that's your humerus, okay, normal position. What it also does is it causes flexion of the humerus. Which fibers bring about flexion? It's the clavicular fiber. So the anterior lamina which causes flexion of the humerus at the glenoid cavity. How do I bring this back? How do I bring them back? I bring them back by contraction of my sternocostal fibers. Okay, so clavicular fibers flexion, sternocostal fibers kind of extension by bringing the flexed arm back to normal position. It is also an accessory muscle of inspiration. When you are not able to breathe at all, you're probably going to put your hands somewhere and take in a deep breath. Do it. You will find automatically you're using your pectoralis major muscles. You have to do these things, students. You can't just randomly listen to me. Try it out yourself. You're not likely to forget. So what are its actions? It is helping in medial rotation, adduction, flexion clavicular fibers, extension sternocostal fibers, accessory muscle of inspiration. That completes your pectoralis major. How will you test the muscle? See, if you just try and pick up something really heavy, try it out. Pick up something really heavy, automatically your clavicular set of pectoralis major muscles will become prominent. Okay, and press your fist together, which is what the bodybuilders do. I'm sure you understand where I'm going from here. Usually they will keep their arms together in this manner and press. When they press, automatically their pectoralis major becomes prominent. Okay, try it out. Stand in front of the mirror and do these things. Then you're not likely to forget. Anatomy is about our body. Try it out. Don't just read words and remember words. Remember the reality of human body. Right. So, applied anatomy of pectoralis major. Remember, this is associated with something called Poland syndrome. Usually the sternocostal fibers are missing. Okay, you will find loads of images about this on the internet. Do go and check those images out. Associated with webbing of digits. It's a syndrome, right? So, missing sternocostal fibers of pectoralis major along with webbing of the digits. Rarely the clavicular fibers may also be missing. Pectoralis major is associated with sometimes formation of a tumor, which because it's lying deep to mammary gland can be sometimes mistaken for a breast cancer. Okay, so that's about the pectoralis major. Let's move on to the rest of the class, which is very short. Pectoralis minor, a small triangular muscle, as you can see here. It's called as the key muscle of pectoralis region. Why key? Why is it called key? Because there are a lot of things associated with it. That's all. The muscle itself is pretty tiny. Let's understand. So that's the pectoralis major which we just discussed. Let's remove it. What is lying below it? Pectoralis minor. Very nice. So it lies deep to pectoralis major. This muscle is attached superiorly. That's the pectoralis minor, attached superiorly to the clavipectoral fascia, which splits to enclose it. Clavipectoral fascia splits to enclose pectoralis minor. Inferiorly attached to the suspensory ligament of axilla, which as you can see is helping to hold up the axillary fascia. The pectoralis minor is also very important because it lies over, across the axillary artery. Come take a look. Can you see? That's the pectoralis minor. It is lying over this axillary artery, dividing it into three parts. First part before the muscle, second part behind the muscle, third part distal to the muscle. Okay. So thus it covers the axillary artery and also covers majority of the brachial plexus, one of the branches of which is the medial pectoral nerve, pierces the pectoralis minor. Right. Action is protraction of scapula. This is something you should understand. That's the normal anatomical position of scapula. Give me a minute. Remember, when you're holding your scapula, always point the coracoid process towards your examiner. If you don't like the examiner, which happens very often, imagine that you're shooting your examiner with the coracoid process. That will give you happiness. Whatever rocks your boat. Just remember, coracoid process directly आगे आना चाहिए. ठीक है? Scapula ऐसा नहीं होना चाहिए. It should not be looking on the side. It should be looking in the front towards your examiner. Okay. Now with this scapula in place, how does pectoralis minor act? It acts by protracting it forwards like this in association with serratus anterior. SA. Okay. Let's do this on ourselves now. Just imagine, keep your mind on your scapula and imagine you're doing this, which is a punching kind of action. So your scapula gets pulled forwards along the chest wall. This is action of pectoralis minor. Of course, it also helps to pull your shoulders downwards. Many times if you're doing some exercises, which I hope you are asked to pull your shoulders down, depress your shoulder, pectoralis minor. Right. While we're talking about pectoralis minor, you must always discuss clavipectoral fascia, which is, like you can see, please see the green colored sheet. It's a sheet that completely encloses the pectoralis minor, medially attached to the anterior intercostal membrane between first, second and third ribs, laterally attached to the coracoid process, and the coracoclavicular ligament. Okay. It superiorly encloses the subclavius muscle, inferiorly encloses the pectoralis minor muscle. This is your clavipectoral fascia. Okay. And it is pierced by a number of structures. It continues down and becomes the suspensory ligament of axilla. Okay. So what are the structures piercing clavipectoral fascia? Tender, loving care. What is T standing for? Thoracoacromial artery. Loving, lateral pectoral nerve. Loving, lymphatics. Care, cephalic vein. So let's take a look. Cephalic vein, thoracoacromial artery, lateral pectoral nerve. Lymphatics you can't draw. Please practice this diagram well, because clavipectoral fascia is a very common short note. Right. So tender, loving care. Do this with me. T for thoracoacromial artery, L for lateral pectoral nerve, L for lymphatics of the pectoral region, and C for cephalic vein. You should know this in your sleep also. It is that often asked. Right. Subclavius muscle, it's just a tiny little muscle that is going from your first rib and getting inserted onto the clavicle, enclosed by clavipectoral fascia. You needn't know more than that. Supplied by nerve to subclavius. There's a question I want to ask you. What is Erb's point? Now, ma'am, Erb's point is in head neck region. Why are you asking this question now? There is a reason why I'm asking it. Can you tell me why I am asking you Erb's point today when I'm teaching you subclavius? Please find out. Give me the answer in the comment section. Right. Let's talk about the last muscle, the serratus anterior. For that, I want you to look at the scapula here or here. This is the costal surface of scapula, which gives attachment to the serratus anterior right from the upper angle to the lower angle here. Okay. So, this is pectoralis minor and that's the attachment of serratus anterior. With this information, let's go here and origin of serratus anterior. Serratus anterior takes origin from first 8 ribs. First digitation getting attached to from the superior angle to the spine of scapula here. Second and third along the costal surface of medial border. And the rest of the digitations go to the inferior angle of scapula. This is your serratus anterior. Ribs se scapula tak. From ribs to scapula. Which ribs? First to 8th. To where? Costal surface of scapula. What will it do? What it will do is, because it's attached here, it will pull your scapula forwards, which is what happens when you are inspired to punch somebody, isn't it? It's a punching muscle. Supplied by C5, C6, C7, long thoracic nerve of bell. Long thoracic nerve of bell. Right, that's the nerve. So this is what she is doing. She is doing punching. Who is helping her in doing punching? Pectoralis minor. Okay. The muscle is also helping in rotation of scapula, which is required while abduction at the shoulder joint. This I will be discussing further in my lecture on shoulder joint. Do please attend that. Right. Last slide. What is winging of scapula? When your long thoracic nerve of bell is damaged, the serratus anterior gets paralyzed. It is unable to hold the scapula flush with your thoracic cage. So now your scapula begins to move, begins to protrude backwards like this, like a wing of a bird. Hence it's called winging of scapula. Okay. So why would you damage your long thoracic nerve? This is seen when people are carrying a lot of heavy loads like porters, or you're doing some surgery in the lower posterior triangle region, you might damage the long thoracic nerve. Right. So students, that's winging of scapula. So what did you learn today? You learned that the pectoral region is covered by skin, superficial fascia and its contents, deep fascia covering pectoralis major, deep all the muscles of this region including pectoralis major, which comes as a short note, pectoralis minor, clavipectoral fascia short note, subclavius, serratus anterior. What is winging of scapula? This is what we learned today. I suggest you revise it once and take it into your permanent memory area of your brain. Right. Students, if you enjoyed this lecture, do please like and subscribe to my channel. Remember to share your thoughts in the comment section. I would love to know if I am helping you in any way in your studies. Right. So thank you students. I enjoyed taking this lecture. I hope it helps you in the dissection of pectoral region. See you across the screen in some other video. Bye.